So I guess we're gonna get started because this is one of the few the second hybrid event we have actually, and so we have a bunch of people joining us online. Hello, and welcome to all of you here. My name is Punar Karajamandic. I am the founding director of the Business Advancement Center for Health. I'm a professor here at the Carlson School in the Department of Finance. I'm a health economist, and we are so excited to have Julie and Liz here today to tell us about their work. I know of their work, but I think I will learn so much. I actually brought my notepad, so all the very, very cool data. The one thing that I do want to share is we had one event with a bunch of leadership from different healthcare organizations, and one of the CEOs of a very large health system said, you know, Minnesota is so innovative, and we should like really emphasize and embrace that even more. Like for and highlighted Minnesota community measurement as a hallmark of that innovation. And she said, you know, we decided we want to compete on quality, so we have Minnesota community measurement, and we define what that means, and we compete on it. And I think that's a really cool thing for our community to have certain set markers. And I always say, you know, we can't improve value and quality if we can't measure it. So it's so good that to have you here. So thank you so much. Very brief introductions. I know that Julie and Liz will team tag, but so I'll introduce both of you so I don't interrupt your presentation. But Julie is the president and the CEO of the Minnesota Community Measurement, which is a multi-stakeholder nonprofit which empowers healthcare decision makers with data to improve healthcare quality, affordability, and equity. And Julie has 25 years of experience in healthcare policy and reforms to improve healthcare cost, quality, access. And she joined Minnesota Community Measurement as its president in 2017. There at Minnesota Community Measurement, she has led the strategic focus on leveraging the organization's strength as a convener and trusted source of data to make measurement more meaningful, timely, and actionable in ways that support better healthcare quality, affordability, and health equity. And prior to joining the Minnesota Community Measurement, we actually overlapped a little bit in the School of Public Health. She served as the director of a Minnesota State Employee Group Insurance Program as well, and the deputy director of SHADAC, which is a very interesting, another innovative center we have at the University of Minnesota, which is State Health Access Data Assistance Center. And she has also held a role as the director of the Health Economics Program at the Minnesota Department of Health. So thank you, Julie. And then I have Liz Cinquense, who is the Chief Operating Officer of Minnesota Community Measurement, with more than 20 years of experience in advancing healthcare policy, implementing programs, and building business models that leverage data-oriented strategies and solutions to advance improvements in healthcare. And hence the synergy with our center, Business Advancement Center for Health, with a mission to improve value and equity in healthcare through business innovations, business-driven new models, next-generation business models. Melissa has been instrumental in the design of data governance, infrastructure, and analytics solutions that deliver actionable information to advance care and improve population health. And prior to joining Minnesota Community Measurement, this served as the executive director of Minnesota Pharmacists Association after several years as its vice president of public affairs. So I welcome both Julie and Liz, and we can't wait to hear from you. And a little bit of a hint to our students who may join us, we have an interdisciplinary health data competition coming up. This will be our fourth, Kim, do we have the fourth one this year? I guess so, in March. And it will be on that theme of quality and measurement. So listening carefully and ask questions. Thank you.
Thank you, Pinar. What a nice introduction. You know, I tell people all the time about how important Minnesota community measurement is to the community, but it was really nice to hear those words coming from the CEO of a healthcare system. It must mean that they're true. So I'm Julie Sonier. Really glad to be here today. It's so exciting to be in a room full of live people. Welcome also to everyone who's online. I assume that you guys will keep track, like if there's a sound problem or something or questions online, you guys will let us know. Perfect. Well, thank you so much for the opportunity to come and talk with you today. We are really looking forward to sharing information about Minnesota community measurement, how we support healthcare research. Yep. How do I adjust it? Like,
I know the lapel mics, it's always hard as you turn your head.
all right. Oh, I bet that's better. All right, we will try that. I could also hold it. Okay. All right, now we know. Hopefully that's better. We have always had a relationship with researchers since Minnesota Community Measurement was founded, but a lot of what we've been doing in the past few years really offers the potential for expanding those relationships in some ways that we find pretty exciting. And Liz will share with you some real life examples of projects that are going on or projects that we're thinking about that I think will help to make that idea a lot more concrete. But we look forward to hearing your ideas as well. First, though, I think it makes some sense to spend a little bit of time talking about the foundations of our work and how the organization has evolved over time. So I'm going to talk about the various roles that we play in the community, as well as the data that we collect and also how those data are used. And then Liz will talk about some of the ways that our role in the community is evolving, including the ways that we collect data and the ways that we work with researchers. So just going back to the sort of the ancient history of our founding. So in the early 2000s, I want to say it was about 2001 or 2002, Minnesota Community Measurement was started as a pilot project of a number of health plans. Yeah. Yes. All right. We were started as a collaboration of health plans to see if they could learn anything useful by combining their data that they had on healthcare quality, kind of what healthcare quality measures existed at the time, but to see if we could learn anything useful about quality at the medical group or the clinic level, which is, of course, where quality happens, right? So quality isn't happening at health plans. And that pilot project was a success. And that's what led to the establishment of Minnesota Community Measurement as an independent nonprofit in 2005. And our board of directors includes perspectives from healthcare providers, from health plans, employers, consumers, researchers, and state government. So pretty much anyone that you can think of has a seat at the table. One other important piece of history to know is that there was state legislation in 2008 that established the Minnesota Department of Health's statewide quality reporting and measurement system. And in part, that was specifically to accelerate and expand the impact that Minnesota Community Measurement was already having. So we are a contractor to the state for that particular piece of work, which is one component of the broader measurement and reporting that we do. So Minnesota Community Measurement grew out of the idea that we could accomplish more together when we collaborate to do three things. So the first one is bringing people together to agree on common priorities, specifically related to measurement. So thinking about where can we work together to reduce fragmentation of effort and reduce duplication of efforts, and just kind of all get on the same page about a common set of quality measures that are important to all of us that we should work on together. The second thing is to create a single trusted source of data that's meaningful and powerful. So combining data across different sources, and in the early days, it was combining data from different health plans. And nowadays it is also combining clinical data from medical groups. But the idea is when you have this one source of data that is sort of apples to apples, from all of the different sources that it comes from, that it gives you so much more information and so much more actionable information that can be used to improve quality. And then the third piece of this is to make that data transparent to empower decision makers. And it's data on healthcare quality, cost, and equity. And I should also mention that in all of this work, trust is a really essential ingredient. So if the data aren't trusted, they won't be used. And so it's really important to spend a lot of time building those relationships. And sort of one of the issues with the data is if people don't believe that they're doing things the same, that the people across the street are doing it the same way that they are, then they are going to perhaps dismiss the results and not necessarily act on them. So lots and lots of time spent on building the trust, all of the validation of data to make sure that everyone is playing by the same rules. So our organizational mission statement is that Minnesota Community Measurement empowers healthcare decision makers, and that's decision makers of all types, with meaningful data to drive improvement. And we wear several different hats as we think about how do we go about this work. Really at the core of everything, as I just said, is the role that we play as a convener and a facilitator of multi-stakeholder collaboration. So none of the rest of what we do would be possible without that. And so I think it's really hard to overstate the importance of that role as a convener. These are really the processes that help our stakeholders decide on priorities and how we're going to work together. The second role that we play is as a measure developer. So we are known nationally as a developer of quality measures. We also perform statewide data collection, validation, and aggregation for a full slate of quality, cost, and utilization measures. And then finally, we make that information publicly transparent in a variety of ways. So I'm going to spend time talking in a little bit more depth about each one of these roles. But first, I want to talk just a little bit about how the data are used. So we know that the data are powerful and that they motivate change, as evidenced by the CEO testimonial. And the data are used in many different ways. So, for example, healthcare providers use the data to compare themselves to others and to statewide averages. And they also use it to drive their quality improvement strategies. Private payers and Medicaid use the data in value-based contracting. And they're also used to understand and make progress on reducing disparities. I'll share some examples of our disparities data. And then finally, they're an incredibly rich and detailed source of information that is used by researchers to understand what works to improve healthcare quality and affordability. So, what did I just do? Okay, I won't do that again. I won't press that button again. So now we're going to dive a little bit deeper on each of those 4 core activities, starting with the multi-stakeholder convening. So one way that I like to describe this is we tackle some really big, complicated issues where there's a clear benefit to working together rather than separately. And setting measurement priorities is one of those. It's the very first example. It's the reason people convened in the first place to create this organization. But really the questions are, what are the best use of limited resources for measurement? So it's not unlimited. We don't have unlimited time. We don't have unlimited attention. Like people can only focus on so many things at once. And there's limited money that's useful for that. So the question is, where can we have the most impact together? A second kind of big complicated area that we've tackled in the past is around setting common standards and best practices for what it means to collect race, ethnicity, language, and country of origin data. So this is where healthcare providers are collecting this data from patients at the point of care. So there was a real need. We've known in Minnesota for a long, long time that we have large and persistent health disparities. And without data, there's not a whole lot we necessarily can do to make progress on that. So data are part of starting to make progress on it. But the very first thing is figuring out how do we get everybody to collect this data in the same way so that people trust that it means the same thing, or that the data are complete enough so that we can trust it. So if the data are missing on 70% of the patients, well, not really sure what you can credibly do with it. So we've been working on this issue since about 2008. And slowly over time, people have progressed to the point where the data are really high quality, really complete, and that's really forms the foundation of an annual report that we publish on disparities by race, ethnicity, language, and country of origin, the most recent one of which came out yesterday. A third area of, I don't know if the battery might be going on this. I can't hear it. Okay, I think we're okay for the moment. One of the third areas, and we won't talk about this very much today, but one of the other areas that we're working on is kind of like this big, huge opportunity for collaboration is on opportunities to streamline data flows. So much like, back in the day, people said, well, all the health plans want me to measure diabetes quality, but they want slightly different measures in slightly different ways, and it's driving me crazy. Can't we get all on the same page and do it the same way? We also have started to hear, well, I'm getting all these requests from health plans for like patient level data, and it's really similar data, but it's different formats and it's slightly different things. And boy, it would be really nice if we could all get on the same page and do it the same way. It would save a lot of work and it would free up time and resources to actually work on the quality improvement. And likewise, the data that providers are getting back from payers, they're saying, well, similar data, but it's all coming in different formats. Sometimes it's a PDF, sometimes it's something else. I can't combine it, and it's like one small slice of my population, and if I could look at the whole population, boy, we could do a lot more powerful work around quality improvement. So that is something that we're working on. We won't spend much time talking about it today. And then the last piece is about, much like the work that we did earlier around standardizing practices on collection of data for race and ethnicity, now we are currently engaged in trying to figure out what can we do around social risk factors data collection. And it's not so much about everybody collecting asking the same questions in the same way. That horse has kind of left the barn, and sort of we have a garden where 1,000 flowers are blooming on that. But it's really about, can we harmonize that data to make common meaning out of what people are already asking people. So let me dive just a little bit deeper into the prioritization of measures, which is, one of the important parts of the multi-stakeholder convening. So on this topic, there's 5 ways that we think about what makes a measure, how to prioritize measure. The first way is that the measure has to be meaningful importance. So that means maybe it's about a health condition that affects a lot of people, or maybe it's something that has a really big health impact on the people it does affect. Part of the consideration here is that measures of outcomes are prioritized over processes. I'll talk a little bit more in a minute about the difference between outcome and process measures. The second criteria is that it has to be evidence-based. So it needs to be grounded in scientific research evidence about what works, rather than just being something that we think would be nice to know. The third one is that there has to be opportunity for improvement. So we could measure lots of things where everyone's doing really well, and if everyone's at or above 90% on a certain measure, we're not really sure that's the most worthwhile activity to be doing, as opposed to something where there's much more room for and need for improvement. So knowing that there's a gap versus desired outcomes, either at the statewide level or variation across providers, that tells us that there's room. The high performing providers are telling us there's room for others to improve. Those are things that we look for in terms of opportunity for improvement. The measure has to be feasible, which means that it can be collected without undue burden. So it is a lot easier, especially these days, to collect things that are readily available in a discrete field in an electronic health record than something, for example, that requires being abstracted by hand. And then the last criteria here is that the measure has to be actionable, which means that providers' actions can influence the measure's results. And it doesn't mean they can control the results completely, because there's always often going to be factors outside of a provider's control. Some of those social risk factors that I talked about are among those things, but there are ways for adjusting measures for those other types of factors. So it's just that the provider's actions can influence the measure results. And I think this is my last slide on the multi-stakeholder convening piece. But it really is about, thinking about all of those criteria for selecting measures, but also thinking about kind of having a balanced range of topics that you're collecting. So what we collect currently is kind of a full range of measures that cover preventive care, chronic disease management, specialty care. So for example, outcomes from orthopedic surgery or cancer care, as well as cost measures. So total cost, prices, and utilization. And this is where it's useful to talk about the difference between, excuse me, process and outcome measure. So a process measure you can think about as, for example, did someone who has diabetes have their blood sugar tested or not? And the outcome measure would be, what did that test show? Is how well the patient's blood sugar is controlled. And so the outcome is really much more meaningful and actionable than the process piece. There's a special category of outcome measures called patient-reported outcomes, which are really being prioritized nationally. And that's an area actually where Minnesota Community Measurement has done a lot of nation-leading work in developing those measures. So moving on to our role as a measure developer. The world of healthcare quality measurement, I am sorry to say, changes very slowly. So some of the measures that that people were getting together in this pilot project back in the early 2000s to say, gosh, wouldn't it be great if we could combine our data and do those things? Some of those measures are still in wide use, even though largely they were claims-based measures, process-type measures, right? Did people get a blood test or not, or those sorts of things. And this world has been very slow to change. And I have to say that the availability of clinical data has been one of the barriers to that. And it's something that we in Minnesota kind of take for granted these days, because that's what Minnesota Community Measurement does. We collect clinical data for quality measurement, but I participated in a lot of national conversations where people go, we're never going to have clinical data for quality measurement. Where we get to raise our hands and say, well, we've been doing it for 15 years. And they go, but you're Minnesota. We don't think we can do it. So from our very early days, our stakeholders were not very satisfied with the measures that were available to them. And so they wanted to push the envelope into what they viewed as outcomes that really matter. And that's what led to Minnesota Community Measurement becoming a nationally known developer of quality measures, with an emphasis on clinical outcomes and especially patient-reported outcomes. So some examples on the screen right now of areas where we have developed measures, and these are things that we are actively measuring. So outcomes, optimal asthma control, optimal diabetes care, including outcomes and not just processes, vascular disease, depression, spine and knee surgery outcome measures, as well as a measure of symptom management during chemotherapy for cancer care. So many of these measures are nationally endorsed and they're used in national programs. A number of measures that are endorsed by the National Quality Forum, which is considered kind of the gold standard of endorsing measures. Several measures that are used by CMS in federal programs, measures that are included in the Core Quality Measures Collaborative. That's a public-private collaborative that is at the national level trying to get people on the same page about quality measures that are used in value-based contracting, and then some measures that have been adapted by HEDIS for their own use. So in terms of the data collection and validation itself, there are a few things that I think we should be particularly proud of in Minnesota as it relates to organizations like Minnesota Community Measurement that do some of the same work in other parts of the country, but I think no one is doing the breadth and the depth of the measurement and public reporting that we are doing. So the scope of our work includes healthcare quality and cost and equity, and we're gathering claims data and clinical data. I don't know of another organization like this that is doing all of that. So some of them might be doing clinical data for quality measures. Some are doing, cost measures from all payer claims databases, but, very, very rare to be doing this full comprehensive breadth of this work. A second strength that I would highlight is the comprehensiveness and the completeness of the data. So nearly universal participation from providers. And by that, I mean nearly all primary care providers in the state, as well as specialists where that's appropriate and applicable, right? So, for the diabetes measures, it includes endocrinologists or, as allergy and asthma specialists for the asthma measures. The clinical data that we collect from providers is their entire patient population to whom the measure applies, and all payers. So it's their full patient population. And we've gotten to the point slowly over many years where at this point, 90 to 95% completeness of the race data that we have validated as being collected using best practices. And then the final thing that I'll highlight in terms of the strengths of the data collection that we've built here is the standards for the race, ethnicity, language, and country of origin, the data collection and public reporting. And so, it's one thing to sort of establish a field in a database and say, these are the race fields. It is an entirely different thing to focus on actually how those data are being collected by providers and making sure that sort of building that trust in the community about the apples to apples comparison. So really how it's being collected is very, very important in addition to like what is collected, what it looks like in a database. So I don't want to spend a ton of time on this one, but also wanted to make sure that you're aware that we also collect data from health plans. So most of what I've been talking about up till now, especially the race ethnicity data, that applies to the clinical data that we're collecting directly from medical groups. But we are collecting data from health plans in a couple of ways. So we're collecting aggregated data from health plans on select HEDIS quality measures. So we're combining that data across the plans in order to be able to publicly report it at the medical group level. And then we're also collecting cost and utilization data. So we are not an all-payer claims database, but what we're collecting is basically summarized patient level data on annual cost and utilization for the commercial health insurance market. And that forms the basis of one of the reports that we publish every year. So the last of the 4 pieces that I wanted to highlight is the public transparency piece. And we do publish 4 summary reports that we release annually. So one of them is the healthcare quality reports, kind of the overview of healthcare quality. This year we've actually split that one up into 2 parts in order to be more timely with releasing that data on a cycle that's similar to when we collect it. It comes in at different times of year, and we wanted to make the information available in a timely way. So we've split it up into 2 parts this year. The disparities by race, ethnicity, language, and country of origin report, which we just updated yesterday. A cost and utilization report, and then finally another disparities report, which is about disparities by insurance type. And that report is done through a contract with the Minnesota Department of Human Services, and it's really specific to their role as a healthcare purchaser in understanding kind of what their, what are the variations within the patient population that they are responsible for. So just a couple of examples of some of the analysis in these reports. So this one is from the Healthcare Quality Report, and it's an illustration of quality variation across medical groups. And so across the bottom here are distinct quality measures. And what you see is really a box plot of the variation in performance across medical groups. So every dot in the chart is a medical group. The sizes vary by the size of the numbers of people in the denominator of that measure. But really, you can see a ton of variation, including for some measures, a variation almost from 0 to 100% in provider performance across those measures. So, lots and lots of room for improvement across the measures. The next example that I wanted to share with you is about variation in cost. And this one is by region of the state. And this is really, really interesting. So it's based on the region where the patient lives. So if I live in, St. Paul and I'm going to get care in Rochester, this map is assigning me to St. Paul because it's based on where I live. And it's a total cost of care measure, which is all of the care that a person receives throughout the course of the year. We have an attribution methodology that attributes patients to primary care medical groups, and all of the costs sort of get attributed there. But what's really interesting about this analysis is that we have a few areas in the state that are lower cost than average. So it's the St. Cloud area. The Twin Cities are lower cost than average, but they're lower cost for different reasons. So in St. Cloud, there's lower utilization of care, and in the Twin Cities, prices are lower than average compared to the rest of the state. And down in the southeast part of the state is where you see that their costs are highest, and that is primarily due to prices. So the last example that I'm going to share with you is about disparities in colon cancer screening. And this is disparities by race and ethnicity. Some really, really stark disparities. And we're comparing here to the statewide average, which this is the data from the report that we just published yesterday. So it's data for care provided in calendar year 2021. The statewide average was about 72.2%. And this is the difference by group in percentage points from that statewide average. So especially for Black, Indigenous, Native Hawaiian, and Hispanic patients, 13 to 18 points below the statewide average. And this again is data that we you know, people call us from across the country wondering, you know, how did you get that data, and, you know, wanting to know how they can do that themselves. To this day, they still call us asking that.
Could you use the mic? Yeah.
So the question is about whether these population groups are seeking less screening. So, you know, it's all based on sort of a frequency of screening that's recommended by the U.S. Preventive Services Task Force. So it means that they are less likely to be up to date on recommended screenings. Does that make sense? So I talked a little bit earlier about, you know, some of the impact and influence that the data have. You know, they're used in quality improvement and used in value-based contracting and all of that. One of the most powerful examples, though, is this chart. And you're not supposed to be able to read this chart on the screen. But this is a chart that we often include in our healthcare quality report. It is a chart that designates high-performing medical groups, which are those that are at or above the statewide average in more than half of the measures that apply to them. And I will tell you that medical groups are keenly interested in being listed as a high-performing medical group. They're keenly interested in their performance compared to their peers, and really, really want to be sort of designated this way. And, you know, another sort of way to think about this is that people will often come to us and ask us, you know, they say, well, you know, we have a strong interest in measuring, you know, X, Y, or Z. So a couple of years ago, it was lung cancer screening. And people have told me that if I want that to happen, I have to talk to Minnesota Community Measurement and get you guys to do it, or else no one will pay attention to it. So that's one of the ways that we know the work has an impact, and others telling us that the measures that we have are helping to drive investment decisions in quality improvement inside of health systems. So really, just to sum up, and just as I turn it over to Liz, you know, we have really built what I would say is an incredible community asset here in Minnesota for collecting and using data to drive improvement in healthcare. So we focus on topics that are meaningful and important, you know, have a strong reputation as a trusted, objective source of information that's not only complete in terms of you know, who participates, but also the quality of the underlying data. So really, really strong foundation to start from. And I'm going to turn it over to Liz to talk about how our role is evolving, including the ways that we collect data and the ways that we work with researchers.
Great. Thank you, Julie. I just want to do a little sound check before I get started. Should I use the other mic, or is this one okay? Okay. Sure. Just let me know if I need to switch. Well, hello, everyone. Again, my name is Liz Chinqueonche. I'm the Chief Operating Officer for Minnesota Community Measurement, and I've been with the organization for just over 5 years. I was thinking as we were putting this presentation together, just a reflection on those 5 years and how much listening that we did at the very beginning, right? So Julie laid the groundwork well and covered everything that has been included in our history as the foundation of Minnesota Community Measurement. So measure development. Sure. Yep. Okay. So measure development, data collection, validation, aggregation, public transparency, those are all the cornerstones of our work. And when we came on just over 5 years ago, we went out and spoke with the stakeholders around the state to just really get a sense for if we are going to take this work to the next level, what is it that we need to do? What are the additional needs that weren't part of that original foundation that we need to be able to build on? And there were 3 things that really emerged from those conversations. The first was that we needed to modernize the way that we were doing data collection and reporting. We needed to be in tune and in touch with evolving needs around value-based care and what was needed to really move the needle on that. And we also needed to find some additional ways that we could actively partner to drive improvement. So these are the areas that I'm going to be focusing on today. So when we heard those sort of top level ideas about where we needed to go, we wanted to go a bit deeper in understanding what the community meant by that. So in terms of modernizing data collection and reporting, what people were really looking for was for us to find a way that we could reduce the burden of data collection and data submission so that people could submit data and information more frequently and in return have more timely information. So historically, we've only been able to report on those clinical quality measures once a year. And part of that, part of the rationale for that timing was just that it's a lot of work to submit that quality data. So how do we get the burden level down so we can get the timeliness and frequency of submission up and the relevance of the information increased and more timely and actionable? Secondly, in terms of meeting evolving needs to advance value-based care and payment, we needed to address the data barriers that existed out there. Julie talked a little bit earlier about streamlining data flows. That's one that we're continuing to try to tackle. But just to continually keep our finger on the pulse of what are those data barriers and what role is it that Minnesota Community Measurement can play. And where we can, provide some technology support based on those needs. And then lastly, and what we're hoping to spend a fair amount of time on today, is related to actively partnering to drive improvement by engaging with research partners on studies that further this work to support our state and nonprofit partners on advancing common goals and really addressing the highest areas of need on an ongoing basis, which are going to continue to evolve. So I want to start a little bit by talking about our modernized approach to data collection and reporting. And some of you may have heard of our new PIPE system. It's important to note that this is both a technology platform as well as a method for measuring clinical quality. So on the left side of the screen, you can see our historic method. We called that direct data submission, or DDS. And each of those little boxes on that side of the screen represent an individual measure specification. So if you can imagine being a medical group with a limited staff in terms of your data resources, having to separately understand each of those measure specifications, build the queries, extract the data, validate the data, submit them into Minnesota Community Measurement, and then multiply that across all of the medical groups in the state, you can see the burden that our stakeholders were calling for us to reduce. So again, we have moved to the PIPE method. We are in the process of transitioning all of the medical groups in the state onto this method, and it relies on a single measure specification. So they are pulling a broader set of data that we can use to centrally apply each of those measure specifications, greatly reducing their burden and allowing them to submit the data more frequently and allowing us to provide them with more timely and actionable feedback. So you might want to know what information is included in that PIPE data standard. So there are 9 different data files that are coming in from the medical groups that submit data to Minnesota Community Measurement. All of it is centered around a demographic file that we are able to use to link across the other 8 files included. But we are gathering encounter data or CPT data, problem lists, a blood pressure file, medications, allergies, labs and procedures, patient-reported outcome assessments, and then there's also an exclusions file. So what advantages does this new approach provide? There's some listed on this screen, but I think we're still adding to this list each and every day. The first 4 items on here were part of the original use case for why we created the PIPE data system. Again, streamlining data collection to reduce that reporting burden, reducing that duplication of effort that was occurring across all of those different medical groups, allowing them to spend their time and focus on improvement initiatives as opposed to data submission. Reduce time and resources for validating and auditing the data. Since we're applying that specification centrally, it's also increasing the trust that the specification is being applied uniformly. And then again, increasing the availability of timely and actionable information for people to adjust and continue advancing improvement goals. The last 2 pieces on this slide, though, came about as we got further along into implementation. And that was just sort of the recognition that we have an increased ability to modify our measure set to respond to changing priorities. Because of the expanded data set, we can also test measures more quickly because we have a base of data to go from. And then lastly, the potential to support more value-added use cases and value-based care. So again, we are in the process of onboarding all of the medical groups in the state onto the PIPE data system, and we anticipate that that will be complete at the end of 2023. So on those last two pieces, as we think about our potential to support value-added use cases and support value-based care, we are continuing to figure out how do we meet evolving needs. So this last year, we convened a work group to look at our processes. How are we doing measurement review? How are we doing prioritization? And how do we do that effectively to really leverage the new system and process that we have? So our subcommittee was convened. They've reported out. We're going to be testing some of those new processes this year. And importantly, incorporating health equity into the review of both our existing measures and the development of new measures. Julie also mentioned earlier the work that we are doing around social risk factor data collection. There are 3 issue briefs I just wanted to point out. They're available on our website, and I think provide some really helpful background on the landscape of what's happening in Minnesota. So the first one talks about a survey that we conducted to really understand what tools are medical groups using today to gather this information, and how much similarity and difference is there, what's the potential for being able to map that. There's also a summary of national activity on social risk factor data collection, which is really important. We try very hard to make sure we are keeping our finger on the pulse of what's going on nationally so that we can align wherever possible. And then I think I'm going to move on to the next one. There is that QR code that's included in the slide will take you directly to those issue briefs. But now I wanted to shift over and talk more about how we're actively partnering to drive improvement. So beyond the data that we publish, we do partner with other organizations on research and evaluation. There are 2 main types of projects. The first one we have been doing since the beginning of Minnesota Community Measurement, and that's participating as a data supplier, right? Research organizations leveraging the core data that Julie talked about earlier in different initiatives. But we are moving more into project-specific data collection, aggregation, analysis, including clinical claims survey and other data. And so I wanted to just share a couple of examples of this with you today. But the foundation for all of it comes out of our core work. So the first is the trust that Julie mentioned that we have as a neutral convener, as a data steward, and the expertise that we have in clinical quality measurement and cost measurement. The second, and really significant, is our legal framework. So in order for us to do the work that we do, we have business associate agreements and data use agreements and a data use policy with all of the medical groups in the state and a vast majority of the health plans. This allows us to really scale quickly. If there's a research project that we want to embark on, we can add by addendum a new initiative that allows us to expand our data collection and to leverage the data that we've already collected in a research project. We also have a secure technical infrastructure that allows us to integrate, validate, analyze, and transmit data in a secure way. We have gone through security assessments. I can't even tell you how many over the last several years as we've been building the PIPE data infrastructure. So again, that connects directly back to that trust factor. And that the fact that that exists and it can be used for other projects is really, really significant. And then also our historical and current data that Julie discussed earlier today. So this first evaluation project example leveraged Minnesota Community Measurement's role as a trusted neutral convener. In this case, we had 3 different parties that had different but aligned interests. We had a funder that was a commercial interest. We had a payer that wanted to understand what the impact of a local intervention was on care outcomes and cost outcomes. And we had a provider network administrator that was interested in demonstrating to the payer the impact of the interventions that they were implementing. So in this case, we served as that neutral source to be able to administer the study. We consulted with them on data collection, data analysis, and then completed the final evaluation. This particular project was testing pharmacy-based interventions on diabetes care. There is a full report on our website from the project that shares the outcomes of that study. The next prototype that I wanted to just bring up is a research project example. And this is from another real project. I'm going to dig into the details of what this project is in a minute. But again, if you look at this picture, Minnesota Community Measurement in the center, all of those legal agreements that I mentioned earlier, we have in place already with the health systems and medical groups on the left, the payers on the right. So the added pieces to this are that we had a new contract with a research organization that needed a few different things. They needed clinical quality data, which we had. They needed clinical care coordination data, which we didn't have. They also needed utilization data from payers, and they needed to do some patient surveys to inform the study. And so in this case, Minnesota Community Measurement stood up a separate portal to be able to bring in the additional clinical data that was needed for care coordination. We were able to contribute our clinical quality data that we had. We were also able to separately share the care coordination rosters with the payers that were participating in the study so that they could aggregate the utilization data and bring it into Minnesota Community Measurement. And then we were able to supply the patient identified information to the survey vendor that then went out and did the survey, the patient surveys. And significantly return a consolidated de-identified data set that the research partner was able to use for data analysis and reporting. I thought it would be helpful for us to dive into this research project a little bit just to make it real and give you an idea of the questions that could be answered using this model. So this is actually a picture that was drawn based off of the Minnesota Care Coordination Effectiveness Study, or MNCARES. The collaborating partners on the study are the Minnesota Department of Health, Minnesota Community Measurement, and the Health Partners Institute. The Health Partners Institute was the lead applicant to the Patient-Centered Outcome Research Institute, or PCORI. I think this mic might be dying a little bit. Can I grab that one, Julie? So again, this is a PCORI-funded study. There were three aims to the study. The main question was comparing two approaches to care coordination for high cost and high need patients in primary care. And specifically, we were trying to compare outcomes from a nursing medical model of care coordination versus a medical social model where the team included a social worker. Importantly, we were trying to identify key components of both models that were associated with better outcomes, and to explore how other organizational, community, care process, and patient factors explain difference in the models and the outcomes. So again, for this study, we needed to be able to compare on quality, on utilization, and on patient-reported outcomes. So the data sources you can see on this screen are the ones that we brought together to be able to supply that de-identified data set to the research institution. So in this case, each component of our foundation was used. So our legal agreements were leveraged to be able to easily create an addendum that engaged both the health plans and the medical groups that participated in the project. Our secure technical infrastructure was expanded to include a specific portal to bring in the study data. And then they leveraged our clinical quality data for the analysis as well. So this is still in progress. There's a lot more information on our website about the MNCARES study. We're just wrapping up the analysis on the historical cohort. There's two cohorts of patients. The first one is looking at what happened during the pandemic and how that influenced care coordination. And then the second is getting at the key aims for the study. So I just wanted to highlight that as an example, but just to kind of back it out a little bit to say at a high level, what types of questions might we be able to partner on? So how do different models of care compare across key metrics? What interventions are most effective in driving improvement? How are outcomes influenced by different factors in care delivery, such as geography, practice setting, or the care team? And how are outcomes influenced by different patient factors, such as the race, ethnicity, language, and country of origin, or social risk factors? We did have a depression care study that also leveraged our data. That particular project was looking at which Minnesota providers are most successful in helping patients achieve depression remission at 6 months. Our depression measures have had very low rates for a number of years. So our needle isn't moving as fast. So why do we have high performers? What's the difference in the approach that they're taking to care delivery versus those that are in low performing clinics? What are the main challenges in improving mental health care from a provider perspective? How does that vary from region to region? Is it the same or is it different? And then what are the enablers of success in achieving better patient outcomes? There's another example, a future concept that we're talking about around comprehensive medication management. Could we pick up a model similar to MNCare's and look at how our CMM service is being delivered in the community? What are the common elements? Where does the service vary? Do patients receiving CMM have better outcomes? What patient outcomes are most impacted by CMM? And how do outcomes of CMM differ in community settings versus those that are in an integrated care system? I actually have a whole page of questions on this topic, but these were 4 that I selected for purposes of today. But we just wanted to share these examples to spur your thinking and get your feedback and ideas on other concepts that could be explored. Our key summary and takeaways, I hope that you'll leave here understanding that MNCM is a trusted and objective source of information on both cost and quality here in Minnesota. But we're not just a source of data. We're driving innovation and improvement by making it easier for healthcare providers and payers to both bring data together and to use it to improve quality, partnering with researchers to understand what works and how we can spread those practices, collaborating with other organizations on priority efforts to drive improvement. And then, also that our stakeholders, which includes everybody here in this room, can accomplish more together than we can on our own. So we really do encourage you to reach out to us with your ideas and thoughts on how we can help advance your work as well. So I'll leave it there, and we're happy to take questions.
Yeah, so thank you so much. So if you have questions, please just use the mic so folks online can also hear us. You can just press the little thing. But I wanted to start with one question now that I have the mic. So in that kind of a framework, in the way we can work with you, let's say there is an intervention that the study is proposing to do, say on health equity, but maybe the study partners or the research partners have convinced several of maybe 1 or 2 of the health plans and maybe 1 or 2 of the medical groups or the health systems. Now, how do those legal agreements would work? Like, can we design studies where you become that trusted sort of data steward and an active partner in the evaluation and analysis, but the analysis include interventions from only a select group of your current partners?
So yeah, yes. I think one of the important, I'm sorry. Sorry about that. So they all look a little bit different, and it kind of depends on what the project is, what the intervention is. But our agreements are scalable. So basically, we have a base data use agreement and business associate agreement that allows Minnesota Community Measurement to do work on behalf of those health plans and those medical groups. On the MNCare's study, we also played an important role in recruitment. right? Because we have existing relationships with these medical groups and payers, and we're able to ask them if they wanted to be part of that study. But yes, I mean, we can authorize whatever is needed in terms of both use of the data that's already come into Minnesota Community Measurement, expanding the uses that are allowed today to also be used for research. We can also enable additional data collection, as we did for the care coordination data, which we didn't have in-house. We can enable the movement of that data. So the survey administrator was an entity that we didn't have a previous relationship with, but the legal agreement authorized us to move the contact information to those patients to the survey vendor for them to do that distribution and collection of the survey data. So you really can do, I mean, it's study dependent, right? It's, you know, what do we need to achieve from that standpoint? But having, I can't tell you how much faster it is to get a legal agreement, a legal addendum through some of these large organizations compared to starting with a brand new, starting from scratch is a lot harder and it takes a lot longer. So I think that actually is one of the reasons why Health Partners Institute chose to partner with us the way that they did, because from a scalability standpoint, we could make it happen on a much faster timeline.
I had a question about, first of all, great work. My goodness, I had no idea this level of data analysis is happening. I mean, there's a big company in town that does this for a lot of money, Optum. So this is good. The question I have is, so it seems like the example that you shared are relevant to like family practice settings, depression, diabetes care. Do you have similar, or can a similar project be done with surgical procedures? We are a big medtech town, and there are a lot of companies who would love to have some kind of neutral data, if you will, you know, as to how different hospitals are providing care on a surgical level for certain interventions. And I don't know.
So that's not data that we collect today. But again, if to the extent that there was a study that needed additional data aggregated, we do have the technical capacity to bring that in and aggregate and validate it. Julie, I don't know if you have any other thoughts that you would want to share on that question, but we haven't had any research studies emerge yet that have asked us to do that work. But from a capability standpoint, we would have no issue bringing that in.
We do have a question online from Jason. So he is asking, are there any particular opportunities that you think Minnesota Community Measurement can help with that you feel are underutilized?
That's a good question, Julie. Do you have anything that comes immediately to mind?
You know, not necessarily. I think our goal today is to really expand awareness of these resources that are available, because I think in general we know that the potential is a lot bigger than sort of what's sort of commonly understood in the community. It's not that there's, though, like a very specific example where we think it's underutilized. It's just that we know that there's really a lot of potential for growth in this area, and I think sort of mutually beneficial work that advances, you know, that advances and probably is consistent with the mission of our organization and consistent with sort of improving the health outcomes and health of Minnesotans as well.
Hi,
I was asking, are there other questions? Go ahead.
yes. So once again, great work. This is phenomenal. I'm happy as a researcher to see there's so much data out there. I have two questions. One is on the data, so and the other on the organization more broadly. On data, do you have identifiers to link what you collect from partners versus claims data? So are there identifiers that I can use both these data sets together?
Yes, so when the data come in from the medical groups, we include the medical record number as well as the member ID for the health plan. So we do routinely link actually between health plan and medical group data.
Okay, amazing. And about the organization, I'm just trying to understand, as a healthcare provider, say health partner clinic, uh, what's what sort of incentive do I have to submit all my data to you, including something that I don't routinely even capture? So I change my way of data capturing. Uh, do you share like an aggregated report? Like what drives them to do this?
Yeah, well, I think that the motivations around really understanding how they compare to others in the community, and the ability for us to understand from a statewide perspective where we are at on quality is a key part of that. But they also do get reports back from us that they can use to inform their quality improvement initiatives that will help them to do better in their value-based contracts and agreements. So there's a lot of different reasons why, and I think we've had a lot of conversations as we've transitioned from our traditional approach to data submission to this new approach. It is a broader data set, but again, it's substantially reducing their burden for the way that the quality measurement is done. And they are seeing our measures in contracts, and that's a powerful motivator as well. But Julie, do you have any other additions on that?
Thank you.
You mentioned contracts from payers, like insurance payers are wanting that kind of data to see how they compare against other providers. Okay. Interesting.
Thank you both. It's been a super informational session. My question kind of relates to the gentleman in front of me. As an individual who works for a local company in town that does this for lots of money, right? So the people that might seek our products and services do so because they want the outcome and the value that we provide, which has similarities to this information. Do you feel as though that the data that is being used by your company may not portray the population as a whole, because it might not come from sources or health plans that maybe have more money or seek more value and aren't willing to give the information to you, but instead might give their data to other companies?
It's an interesting question. On the medical group side, from a completeness standpoint, we are collecting clinical data from literally all of the medical groups in the state, and it's coming directly out of their EHRs. So I don't know that there is a more pure source for that data. Julie, I don't know if you want to weigh in on the claim side, but
Certainly the more complete, the better. I mean, the claims data has always been more limited. Like it's only certain parts of the commercial market. But I would point back to really this question about first of all, kind of the nonprofit mission that we have. So we're not in this to make money. It's really and we're not a consulting company trying to help other people make money. So really kind of a very different purpose, right? But also the importance of collaboration to what we do. So, it's very foundational. So it's, sort of the more the merrier kind of thing, as well as the trust. So not everybody's going to trust another, right? So part of the reason why these research project examples work well with us in the middle is that we don't have a sort of a stake in the outcome. And it's not like we're a payer or a provider that is going to get access to somebody else's sensitive information. So that's part of what I think the difference is.
We have one more question online. So Ross asks, you mentioned PIPE is both a method and data standard. Is or will social risk data and social determinants of health be part of the PIPE standard?
yes. We actually have a roadmap for, is it 2020, 2025? But I do believe we'll beat that deadline.
I do. I'm a huge fangirl, so excited to have you all here today. Two questions. One, curious about, particularly as you're going down the path of sociodemographic data and talking about equity, involvement of community. So not health plan, not, not provider organization, but community members in those conversations, in that interpretation, in that decision-making as it relates to measures, all that kind of stuff. So just curious about that part, kind of current work plans. We would love to partner. I'll put that on the side. And then I'm curious about how much you're leaning into that sort of action and intention toward impact. So sort of that change piece, kind of that engaging with folks to make quality better. I'm thinking particularly from the payer vantage point. Part of the difficulty in value-based payments is traction there, coherence around all of those measures across a set of payers to get provider organizations to kind of get in the game in some way that feels like it actually can yield more significant deltas. So just curious about that part as you all think about sort of maturing where you're headed, how much of kind of a active stance and sort of not push, but, you know, gentle sort of sheepdog towards the market behavior will you be engaging in, or are you thinking about?
So I'll take the second part of your question first, which is really about sort of the crossing over into the quality improvement activities, right? That is something that we have intentionally not done in the past. And in part, it's because of concerns that would compromise the sort of ability to be seen as an objective party. So it would potentially damage the trust in the data, right? In the same ways that we just talked about, like, you know, if you're giving the data to somebody else who has also a competitive interest in it. So it's something that we have not done in the past, that we approach with great caution. I think where there's a strong data component to it, so where there's a project basically where everyone has access to this tool that can be used for quality improvement, and it's just up to you about whether you use that tool or not, I think it is seen as inbounds as opposed to like one-on-one consulting with somebody about their data and what they could do differently. To the first part of your question about community groups, I think there is opportunity and challenge there. So one of the challenges is that this quality measurement stuff is super technical, and it's hard to get what I'll call normal people engaged on it. And so I think the opportunity is to engage communities in these questions, the big questions about what's important and what the priorities are, as opposed to like the technical stuff about measures themselves. But we definitely have progress that we can make there. If you want to talk about ideas for partnerships, that would be wonderful. Yeah.
Well, thank you so much. I think we'll wrap up here so the online folks can, log out if they want. But we're here for a little bit more, let's hang out if you want, and have some snacks and ask maybe more questions, and maybe talk about specific partnership questions as well. But thank you so much, both Julie and Liz, for joining us today. And thank you for all of you to come in and to this event. And, again, if you, things coming up, we have our interdisciplinary health data competition coming up in March. It's for University of Minnesota students, but we would love all of you to reach out if you're interested in being part of that experience as judges and sponsors, and in any way you want to engage in. And then we will have another big convene conference coming up in April 27 is save the date. More on that. Reach out to me or Kim if you have specific ideas you want us to cover in the conference as well, or specific keynotes or other speakers you want to bring in. We just want to hear from you. Thank you so much.
Thank you.